I am also the president of VESPA, which stands for the Veterinary Endocrine Society of the Pacific and Asia. This session will provide tips on how continuous glucose monitoring can improve outcomes in diabetes management in referral practice. So let's begin. This is my disclosure slide. I don't think I've got any conflicts of interest, but you can check and decide for yourself. Let's begin by just thinking about the most common reasons for referral of a diabetic patient. But one would be assessment of complications that have occurred, such as, for instance, DKA or hypoglycemia. A second reason would be identification and management of concurrent conditions, such as hypercortisolism or chronic GI signs. Another reason why people refer is because diabetic control has not been achieved yet, or it is taking too long to achieve it in general practice, and the referring vet has lost confidence or feels that there might be something else going on. And another reason is that it's driven by the owner. The owner wants specialist oversight. That might be because they have high anxiety or that they have very, very high expectations. And our starting point, of course, whenever we're managing a diabetic animal or having to assess one that has been managed by someone else, is that we think about what the goals of therapy are. And you know, ordinarily we would think that they would include resolution of all the clinical signs, avoidance of insulin-induced hypoglycemia, or if we're using SGLT2 inhibitors, we could replace that with avoidance of induced ketosis or ketoacidosis. And especially in the case of diabetic cats, we need to consider if remission is feasible. However, I suggest those are not the most important goals of therapy when we're treating a diabetic animal. These are the goals that I think are the most important. First one is maintenance and enhancement of the animal-owner bond, and that the animal's owner feels supported and that they can easily cope with the care of their diabetic pet. And the reason for this is that there's a very, very high risk of euthanasia. And at the point of referral of a diabetic animal, some owners might be on the brink of euthanasia. So in other words, if we can't find solutions to a situation that they find challenging, then they might decide to not go on at all. And so we've got information about the things that contribute to quality of life for both cats and dogs with diabetes and their owners. There are these two pivotal papers that were published in 2010 and 2012, and I guess you are likely familiar with them. And they showed us clearly that there are a lot of negative impacts of treating a diabetic animal on the owner, and that most of the concerns that people who have diabetic pets noted in these surveys were related to their own lifestyle and their own quality of life rather than the pets, although of course they have a general high level of worry about the pet itself. But just for a moment, I want to focus on the three things that were consistently in both papers found to be really, really positive outcomes of owning a diabetic animal. And this is them. Owners say that when they treated their diabetic dog or cat, they developed a special bond. The companion animal-human bond was enhanced. That they spent more time with their pet, but it wasn't just doing the things like injections and monitoring and so on. They actually played with them more, and they did extra things with their animal because of the improvement in the bond and because because they were treating their diabetic animal. And these are really positive outcomes. And if we're going to save lives, if we're going to be able to help in both general practice and referral practice, we need to highlight these positive outcomes. And so at the start of specialist assessment, we need to address these three issues. We often have someone who is part way through treatment and has a high level of anxiety for some reason, which has prompted the referral. And if we're going to have success, what we need to do is we need to provide long-term perspective. So we have to discuss the expected health and quality of life outcomes that might be achieved with the recommendations that we make. And together with this, we need to provide a roadmap comparing what's been happening in the past with this animal and with the future journey. People have to be given a sense that things can be really good, when that there can be great outcomes for both the animal and the owner if we address the issues that are associated with the case. And finally, what we need to do is we actually need to also provide short-term options. What are we actually going to do now? What's going to happen tomorrow and the day after? What's going to happen before the next reassessment? And what's likely to be achieved? And so somewhere near the beginning of a referral assessment, what I think is really useful to do is an ALIVE clinical score. This is available on the European Society of Veterinary Endocrinology website. In the ALIVE project, ALIVE stands for Agreeing Language in Veterinary Endocrinology, and it's a simple, objective way of finding out where we are now. And it entails getting the answers to 4 questions. And many of you will be familiar with this, but it's a good way of orientating both ourselves and the owner to where we are at the moment. So the questions, of course, relate to unintended weight loss, polyuria and polydipsia, appetite, and the animal's attitude and activity. And we end up with a score out of 12. And what we need to do is tell the owner what the score is at the moment. Sometimes we might find out that the score is 0 out of 12. And so a lot of the anxiety that the owner has, perhaps a lot of it is unwarranted. And the main thing that we need to do is relax about the ongoing journey of this animal. But otherwise, we might find that diabetic control is still very poor, despite an enormous amount of effort to get control of it. And at least we can sort of use that as a starting point and work out what we need to do is get control of these things in the most efficient way as possible. And the toolkit typically involves monitoring. And a lot of this monitoring has to be done in the home environment. And this is the benefit as well as the fun, I guess, of diabetes treatment. It makes it different from so many other diseases. Most of the time, especially if we've got a complicated patient, we will usually be using insulin treatment. And we almost always also have to discuss diet, at least in terms of weight management. And now, of course, there's a whole lot of other drugs we can use. We can use SGLT2 inhibitors in cats instead of insulin. We can use GLP-1 receptor agonists in conjunction with insulin treatment. And this is a space where things are evolving all the time. But the whole focus of this presentation is to talk about continuous glucose monitoring and how that fits in to this scenario. And so we have to, after we've worked out what our goals are for the patient, we then move on to working out how we're going to monitor, how we're going to achieve those goals. And the monitoring options that we discuss and agree upon with the client should be both client and patient focused. It is not our job as specialists or as clinicians to tell people what to do. Our job is to present them with options. We try and find the options that are going to suit them best, but in the end, they have to agree that it's something that they can do. And so we need to be as flexible and creative as possible in order to have the best outcomes for our patients. We have to remember that there are a lot of correct ways to treat and monitor diabetes. There's almost no scientific evidence to show that one method is better than another. And so we can't claim that one is better than the other. There could be one that is best for that particular individual, but not best for an entire population. And so I guess the first point is that although CGM is really cool and very, very helpful in a lot of situations, it's not always the best option. And the situations where I find CGM to be most useful in the referral situation is when I want to rapidly and efficiently achieve diabetic control. If the diabetic clinical score is very high and there's a strong need to get control of that as quickly as possible, or to understand a problem when the information we've got in front of us is confusing, it's difficult to know what's going on, and we need more detail in order to figure it out. There's a lot of information that has been presented in the peer-reviewed literature on continuous glucose monitoring. Almost all of it relates to the Freestyle Libre system. And there are some differences between countries about exactly which systems are which Freestyle Libre systems are available. It also should be acknowledged that although there's not much at all in the scientific literature yet about the whole range of other cost-effective continuous glucose monitoring systems that are available in the world, that there are actually a lot of them. There's a Sinocare ICAN, for example, which is widely used in many countries in Asia, and preliminary information at least shows us that this correlates well with the Freestyle Libre. But anyway, this is the paper I've got up on the screen at the moment was the first one that was published on the Freestyle Libre system in 2016. And it showed that the system was accurate for use in diabetic dogs. This was followed in 2018 by another paper that showed that it was also accurate in the management of DKA in dogs. Then in 2021, we had the first paper of the Freestyle Libre system use in cats, which showed that it was also clinically accurate. But we soon came to realise that there is a difference between the use of this system in dogs and cats. And the big difference is what happens in cats, especially when the blood glucose is in the lower range. And it's important to note that although when the interstitial glucose results are compared with blood glucose results, they're not entirely accurate. And in fact, there's no reason why they should be. They're completely different things. Blood glucose correlates with interstitial glucose, but it's not the same fluid that's being measured. Nevertheless, we have plenty of evidence at this point that there is clinical accuracy, especially in the zones, the most important zones of the error grid analysis. So in other words, when it is important for the blood and the interstitial glucose to give us the same information, the studies show that it comes up to with either 100% or very, very close to 100% reliability. And as I said, this is the paper that was published in 2022, which really started to explore what was happening in the hypo and euglycemic range in cats with the Freestyle Libre 2 system. And what the authors of this paper concluded is that although interstitial glucose underestimates blood glucose throughout most of the hypo and euglycemic range in cats, interstitial glucose generally overestimates it when there is marked hypoglycemia, which they defined as less than 60 milligrams per decilitre. And therefore, it's imperative to evaluate the results in this critical range with caution. And that was super useful for us to know that. But what does it mean from a clinical perspective? We will talk about that a little bit more. Exactly how do we deal with a situation where we really can't tell when we're using CGM whether or not an animal has hypoglycemia or euglycemia. And this is a recent paper that I think is perhaps one of the most interesting of all. This is the first paper that looked at the Freestyle Libre system for monitoring diabetes mellitus from the owner's point of view. And anyone who's used this device for a long time will not be surprised at the results, but it's just nice to see them here in the peer-reviewed literature. So the authors concluded that comparing dogs and cats, a significantly higher number of dogs owners found the Freestyle Libre system to be well tolerated. So that's basically 80% versus 40%. So they also found that it was less invasive. Again, we're looking at 80 versus 40%, and easier to maintain in situ. Again, about 80 versus 40%. So it seems that this system of monitoring is much more acceptable to the owners of diabetic dogs than it is to the owners of diabetic cats, or perhaps to the cats themselves. And I will come back to the first two papers that I mentioned, which are much older papers that were looking at the quality of life of dogs and cats with diabetes. And one of the questions in that survey related to home blood glucose monitoring, which perhaps is one of the most well-used alternatives to continuous glucose monitoring at home. And again, if we compare the two papers, we find a marked difference between the experience of the owners of cats versus the owners of dogs with diabetes. And these papers reported that about 50% of diabetic cat owners said that they checked the cat's blood glucose at home all the time versus about 10% of dog owners. And so we have a situation where for dogs, CGM is a great advance and is really welcomed by a lot of dog owners, whereas in cats, if we're going to be being flexible and offering options, for some animals, CGM will be the best option, but for others, it's worth seeing, can we get the answers that we need using home blood glucose monitoring instead? Okay, so what can we say in 2025 that where are we with continuous glucose monitoring using the Freestyle Libre? Or perhaps if you're in a country where this is not available, one of the other systems. Well, the first thing that we know for sure is that if we're going to use this, we have to manage owner expectations. We have to discuss the possibility or the likelihood of early sensor loss. We don't want people thinking that just because the device is going to last for 14 or 15 days, that's the expectation. In fact, that's definitely not the expectation, especially in diabetic cats. And we have to constantly remember ourselves and remind owners that interstitial glucose is not the same as blood glucose. And there's no reason why it should be. But very importantly, we cannot accurately differentiate euglycemia from hypoglycemia, especially in cats. And we must be, in 2025, we must be prepared to offer alternatives because CGM is not going to be the best option in every case. And if it's not the best option for the case that's in front of you, what are you going to do instead? You need to be prepared for that. We also need to manage our own expectations. I've just gone through a lot of the papers that show us that we should, at this point in time, be able to accept the clinical accuracy of these devices. They are there's nothing that equals their ability to evaluate patterns and trends. And it's an incredibly useful tool when we want to identify and resolve problems. It's not particularly useful to check diabetic control. If we're going to evaluate diabetic control, we do that with the Alive Diabetic Clinical Score or by any other way that we might do clinical assessment. We can't find out how an animal is going clinically by putting a CGM on them. We need to have the skill as clinicians to be able to do that without CGM. But if we need to understand the situation and we need to efficiently fix it, CGM is awesome. And part of managing client expectations is that we need to consider just how we're going to provide them with support. And especially in a referral situation where we have a complex case or where we have problems that we have to resolve. And in fact, almost all the time we are using continuous glucose monitoring in any veterinary capacity, we generally need to provide daily support. And we need to charge for that. Most of the time, I think the best way of doing that is to charge for the daily support at the start. So people pay up front, and then the time is locked in and scheduled for the vet to check the CGM data online and communicate with the owner, and that is already paid for ahead of time. It doesn't make sense for this to be not part of the daily schedule, to be something that specialists and general practitioners are trying to fit in amongst everything else that's going on, perhaps at the end of the day. That's not the way to do this. It needs to be within the schedule. There needs to be time to go through all the continuous glucose monitoring information that we need to look at online with our patients. We also need to have a clear plan for how we're going to manage early sensor loss. And the easiest way of doing that is often to teach the owner how to put the sensor on themselves so that when one stops working, they can replace it during the period of time where we're trying to intensively solve problems. Otherwise, if they are paying for daily support and that's scheduled in the clinician's daily scheduler, then if the animal needs another sensor, the owner comes in with their sensor, that can be applied as part of a prepaid visit, if you like. And the thing that, at least with my clients, that I need to remind people about again and again and again and again is that clients do not need to take any action based on glucose results. I absolutely insist that they turn the notifications off on the app in their phone. It's pointless to have them waking up to alarms because there's high glucose or low glucose when we'd have no plan to do anything about those situations. We're simply gathering information, and then the vet will give recommendations after they've reviewed the data. It's crazy to have a situation where people are having to look at a phone app and take action about their animal or feel that that's the way it's got to be done. And the most likely scenario where people will start frantically Googling to work out what they should do is if their phone says that the glucose is low. And they will then Google what to do if my animal has low blood glucose. And in fact, their animal doesn't necessarily even have low blood glucose. It's got low interstitial glucose, which, at least for a cat, usually means that they're euglycemic. And so they're not the same thing. And one of the things is that when we're talking about it ourselves, we have to be disciplined to not refer to CGM data as blood glucose. We should call it IG or interstitial glucose. And we should correct anybody every single time persistently if they use the wrong terminology and they talk about blood glucose when there's no measurement of blood glucose. It's just an interstitial glucose. I personally think that's very important so that we're clear. Everyone is clear about what we're looking at and what we're doing. So I put all this in red because I think it's really, really important. Um, this is particularly if there's a team that's going to be looking after this patient. You, as the specialist clinician, will do the initial consultation. You'll discuss the goals with the client. You'll know what you want to do, but this needs to be clearly communicated if there is going to be a chance that anybody else on your team is going to be communicating with the owner about the CGM results. So there must be a very clear plan for outpatient use of the CGM. And so if I was looking at the CGM results for a colleague of mine, the first thing I would do is I would look for the goals of the current exercise of CGM monitoring so that I was clear about what we were doing and what the outcomes we're trying to achieve. And this is really essential, but it takes quite a lot of management in a lot of places to ensure that the feedback to the owner from different members of the veterinary team must be consistent. And this is the area that CGM use most commonly falls down in. It's very, very confusing if one vet says one thing, another vet says another thing, and a third vet says something else, and there's different messages all the time. And for a lot of our clients who are very committed and very anxious about their animals, they will try and comply with all the advice, and they come away feeling overwhelmed with all this. It might not even be conflicting, but if it is different, it just adds to the burden of what people think they have to do for their animal rather than simplifying it and finding a solution. And it's actually not very difficult to set up a system where the goals are clearly noted somewhere, that everybody is used to looking at what the current goals are and providing very, very consistent advice. Another thing that happens is in some places is that when there's a team of vets looking at the information, there'll be one person who is the primary clinician for the case, and others will say, oh, it looks okay for today, but we'll wait and see what Dr. So-and-so thinks about that tomorrow. I mean, we do need to move forward. We need to be making progress all the time. And basically, I don't really mind if you don't remember anything else apart from the slides that I've got in red font, because those are the ones I think are the most important tips that I have. So, for example, here's a couple of continuous glucose monitoring results that you might get to look at. On the left, we've got 3 days from the LibreView account. On the right, we've got a screenshot. And despite all our efforts, all of us will have clients who send screenshots of any sort of thing that they might see on their phone. And I think there are so many ways that the continuous glucose information in these 2 images might be interpreted depending on what the goals are. So what we have are periods of high glucose, we have periods of low glucose. The interpretation would be completely different for these results if this was an obese, hypoglycemia prone animal compared with one that has a long history of very poor diabetic control, and our goal is to get control of the glucose. And in both of these images, we're not looking at blood glucose, we're looking at interstitial glucose. And there's no clear pattern about that gives us any information that there is a consistent thing happening each day. There's not even any information about what dose of insulin the owner actually gave or what species it is, really. I haven't even told you that. I can tell you that they're both dogs, or what they're being fed or how well they are, or so on. And we don't need, and we don't want a situation where we have to go trawling through all this back information to try and figure it out for ourselves, why we're looking at this and why we're asked to give some owner support. And just to really, really, really emphasize what happens in cats that have euglycemia, I want to tell you the story about this cat. So this is a cat that was treated with insulin that came into the clinic on the 31st of December, New Year's Eve. And the cat had an episode of clinical hypoglycemia. And so the vet recommended that no more insulin was to be given, and he applied a Freestyle Libre continuous glucose monitor. And what we can see here are the next 2 days of information from this cat that received no insulin at all. And we can see that about 50% of the time, the glucose graph is red. You know, it's in the zone that the Freestyle Libre system signifies as low, and half the time it's blue. And this is what happens if you put a CGM device on a cat that has no diabetes, that has euglycemia. And I'm actually beginning to think that it's a cat thing. I actually think it's these devices are accurate. And I think that because I've spoken to the people who are developing veterinary continuous glucose monitors, and they can't adjust the algorithm to stop the low glucose results. So I'm beginning to suspect that cats actually have low interstitial glucose when their blood glucose is normal. Of course, they can also have low interstitial glucose when their blood glucose is low as well, which we just have to accept. This is the same cat 7 months later. This is July, and this cat has had no insulin treatment since the 31st of December. And for some reason, another Freestyle Libre device was put on the cat. And as you can see, now we have an average interstitial glucose results sitting at about 50 milligrams per deciliter. It's just in the red all the time. And this cat is definitely not having hypoglycemic events. So how do we deal with this? The fact that we're not really sure ever whether or not the low interstitial glucose results mean hypoglycemia or not. Well, this is the results from a dog. And we've got pretty good average interstitial glucose results here. They're mostly less than 180 milligrams per deciliter. And we've got a fairly consistent pattern where the interstitial glucose results tend to always be low in the early hours of the morning and sometimes in the late afternoon as well. And in a dog that has a consistent pattern like this to me would be an indication that this dog should have a lower insulin dose, even if we were to check the blood glucose and find out that the blood glucose was normal during the periods when the interstitial glucose was low. And that's because I think that we can see that a consistent pattern like this signifies that perhaps in the future, the animal could start having hypoglycemia and clinical hypoglycemia, perhaps as the counter-regulatory systems start to fail because of repeated episodes of subclinical hypoglycemia. So I would pay attention to it. But what I don't recommend is flying into a panic and having the animal rush to an emergency centre if there are no clinical signs and the low interstitial glucose is only happening on one day. I would like to see it happening on multiple days before I took action. This is a cat, and this is the way I like to see interstitial glucose results when a diabetic cat is in the phase of insulin withdrawal, hopefully heading towards remission. And I would like to see this for at least 3 or 4 days before I would then decrease the insulin dose and hope that that pattern continues. So we can see very, very stable glucose results here. We can see that they are sometimes going into the red area, but always they are less than 100. All the interstitial glucose results are less than 180 milligrams per deciliter. So again, this would be a situation where the interstitial glucose results would prompt a reduction of the insulin dose. Okay, so I've said that I like using CGM to understand a specific problem. So examples of specific problems where CGM is super useful is if there are variable clinical signs, such as intermittent polydipsia, or there were potentially signs of hypoglycemia, but we're not really sure. And that can be a situation in both dogs and cats, but especially cats. Owners can report virtually identical signs in cats that have lethargy due to severe hypoglycemia as lethargy due to true clinical hypoglycemia. Another specific problem is if everyone thought the animal was going well and then suddenly, unexpectedly, there was an episode of clinical hypoglycemia. And as I said, especially in cats, we can just end up, no matter how good we are at collecting history and doing examination, we can be uncertain whether or not the lethargy that the owner is complaining about is due to hypoglycemia or hyperglycemia, or perhaps is due to something else altogether. It's got nothing at all to do with the diabetes. And CGM is just perfect for these situations. So let's just talk about a diabetic cat that's with periods of lethargy, perhaps with bedwetting. So bedwetting can, of course, be a sign of polyuria in cats, but it can also be a sign of hypoglycemia when they're sleeping. So what is it? What are we looking at? Well, this is the sort of result we might see, where this is a perfect example of what day-to-day variability of glycemic variability can look like in a cat. So we might know that this cat has exactly the same daily routine, and yet we've got 4 days of continuous glucose monitoring here, where if we start on Friday, September 13, for half the day, the cat's actually got really good glycemic control. And then for some reason, at about 4 p.m. on Friday the 13th, it just goes super high. It goes off the scale. And then it stays high all day Saturday and Sunday morning until about 10 a.m. when the glucose comes down and comes back into a range that we would be very comfortable with. And then on Monday the 16th of September, the interstitial glucose results are just low all day, including going way down to the lowest that the device will detect. So what are we looking at here? We've got glycemic variability, or a large degree of glycemic variability. And we've got some clinical signs that indicate that there's concern, something we have to pick up that's probably related to diabetes or possibly related to diabetes. But are we looking at hyperglycemia and euglycemia? In which case, perhaps what we need to do is introduce strategies to bring down the glucose further? Or are we looking at hyperglycemia here combined with hypoglycemia? Well, you can't get the answer by looking at the CGM. The CGM is just a tool to help us solve our problems. Our problems belong to patients, and we have to look at our patient. So here we have 2 Burmese cats. The cat at the top is losing weight, whereas the cat at the bottom has stable weight and possibly is even gaining weight. But if you look at these cats, there's a clear difference in their presentation. The cat at the top has a poor coat. He doesn't appear to be grooming normally. I think that you will agree with me that it looks like he might have some hind leg weakness as well. Whereas the cat at the bottom is fat and glossy and strong. And so that's a good place to start. Already, most of you will be having some ideas about which cat might be having hyperglycemia or versus hypoglycemia. But then what we can do, if this cat has got a continuous glucose monitor on, is we can actually ask the owner to tell us the exact time when the clinical signs are occurring, when the cat is showing the lethargic dull episodes, and we can see what the glucose is at that time. The cat at the top, we discovered that all of those episodes are happening when the interstitial glucose is super high, Whereas the cat at the bottom, we find out that it's actually associated with a low interstitial glucose. And of course, we might have a third scenario where there is no correlation. And we are seeing the owners complaining of these clinical signs when the interstitial glucose is sitting at about 180 or 200, in which case the signs are just not due to diabetes. They're due to something else, which is also an incredibly useful bit of information to have. But based on putting all the information together, I think that we could come up with a plan to see how the cat at the top goes with an increase of the insulin dose, whereas we definitely need to decrease the insulin dose in the cat at the bottom. Okay, the other situation where I think that continuous glucose monitoring is very helpful during specialist assessment is if we identify that the animal has poor diabetic control. And what we want to do is rapidly and efficiently get control of the hyperglycemia. This is a paper that was published in 2023. Many of you might be aware of it. The idea of this paper is that it's a modern approach. It combines modern insulin therapy with modern monitoring, and it goes together. It's difficult to have success with once daily treatment with glargine U300 unless it is combined with the CGM using this protocol. And so how can this happen in a referral situation? Well, I'll just talk you through it. So we talk about Moo. She is one of the first dogs that I ever treated with Toujeo insulin or glargine U300. She's a 6-year-old spayed female Maltese Shih Tzu cross, currently treated with prednisolone forte eye drops. So there are some corticosteroids in the mix. I suspect that this dog also has undiagnosed hypercortisolism or Cushing's syndrome, in addition to what's being caused by those eye drops. She's lethargic still. She's losing weight still, although she's still overweight at this stage. And the owners have found it really stressful to try and follow their vet's advice, which was to match meals with insulin injections. And so he was really, really keen to use a basal insulin once daily. And as I said, the only protocol that I think works to achieve that outcome is to use our protocol, which requires CGM. And so this is Moo's journey. We started on Sunday, the 18th of April, with 9 units of Toujeo insulin once daily. And this was given at about 9:30 a.m. And all of the interstitial glucose results are more than 500 milligrams per deciliter. And so they're just not visible. They're way off the scale of what we can see in LibreView. And so when we have a situation where all of the interstitial glucose results are more than 360 milligrams per deciliter for a day, what we can do is we can increase the insulin dose really rapidly when we're using these modern insulin formulations. And we can do this with in a cat as well, because basically if we're seeing interstitial glucose results that are all over 500 milligrams per deciliter, we are nowhere close to the dose that this animal is going to need to have control of the diabetes. So here we go from 9 units to 11 units to 13 units by the 20th of April. And so, but once we're in the ballpark, we can just keep increasing the insulin dose until we see some interstitial glucose results. And we can do this with any insulin formulation if we're using continuous glucose monitoring. So the efficiency of the protocol is related to the way it's being monitored, not necessarily to the type of insulin. We need to take a lot more care once we're seeing interstitial glucose results that are less than 360 milligrams per deciliter, and especially with the older forms of insulin suspensions, we might need to show a little bit more caution than we would with the modern formulation like Toujeo insulin. But still we can get to that point where we're seeing some interstitial glucose results less than 360 very, very quickly. once we get there, we need to monitor for at least 3 to 5 days. We need to get an idea about whether or not there are any trends to a consistent pattern. And what it is tempting to do with continuous glucose monitoring is to micromanage, but that never works when we're dealing with outpatient diabetic dogs and cats. Instead, a slow, steady approach where we look at the big picture rather than micromanage is always required. So we have gone from, with Moo, we have gone from 9 units of Toujeo insulin on April 18th to 6 days later, we're more than double the dose. We're now at 20 units of Toujeo insulin once daily by April 24. And this is the first day where we see some interstitial glucose results dipping below 360 milligrams per deciliter. And you can see that happen at around lunchtime on the 24th of April. And so the recommendation then would be to give the same insulin dose and see what happens the next day. Well, in her case, what happened was that we got a whole load of super high glucose results again. And so the following day, I was very comfortable to make another jump, this time by 4 units per day, up to 24 units of Toujeo insulin once daily. And now, following that dose, we can see that for at least part of the day, we're getting glucose results that are less than 360. And if we continue then to give this dog 24 units of Toujeo insulin each day, we are now seeing a lot of interstitial glucose results that are less than 360. We've got it dipping down into the red briefly on one day, but there's certainly no consistent pattern of that happening at this point. And so one of the key points when we're using continuous glucose monitoring to get control of an animal's diabetes when there has been very poor diabetic control is that generally we want to aim for a consistent nadir of around 90 milligrams per deciliter. And that is because we tend to have good clinical control when all of or most of the interstitial glucose results are in the 90 to 360 milligram per deciliter range. And if we're going to achieve that range, we have to be hitting that nadir of 90 milligrams per deciliter every day. And especially when we're using basal insulin treatment, such as Tresiba or Toujeo in diabetic dogs, we need to get them down to 5 millimoles per litre or to 90 milligrams per deciliter. And if they're only getting down to, say, 120 or 150 milligrams per deciliter, you need to increase the dose again. And this is just to emphasize that point. So what we have here is a dog that is being treated by a specialist. She knows that the diabetic dog has Cushing syndrome. It's not currently being well managed. That's something that's next on the list of things to do. And on the 8th of May, 9th of May, 10th of May and 11th of May, so the first 4 days of CGM data that we've got here, this dog was being treated with 11 units of Toujeo insulin or Glargine U300 once daily. And you can see that on the 9th of May, we're getting down to a nadir of about 90 milligrams per deciliter. But it's not happening every day. And so what she opted to do was to increase the insulin dose by 1 unit. She went from 11 units to 12 units. And although we can see a lot of missing data over the next 10 days where this dog is receiving 12 units, it's very easy to see that small increase of the Toujeo insulin dose resulted in substantial reduction of the interstitial glucose results, with the nadir now getting down to around 90 milligrams per deciliter every day. But there's very few periods of time where it's going below that. And so what we have is much better diabetic control with not really much increase of a risk of hypoglycemia, and much better clinical control. So if we look again at Moo, this is where we ended up when we were getting down to our nadir consistently of 90 milligrams per deciliter every day. It still looks pretty awful, but it's a whole lot better than the glucose results sitting at more than 500 milligrams per deciliter all day. And what we've got to do is just find out how the dog's going at this point. Well, the first thing is that we've got a very happy owner. He loves using the CGM. He loves looking at stuff on his phone. He really is happy with the more relaxed daily routine of once daily injections and not having to be strict about the timing of feeding. Interestingly, and we see this a lot with the basal insulin treatments, is that the lethargy resolved as soon as she started Toujeo insulin. So as you will recall, she went for about 6 days with all of the interstitial glucose results being well above 400 milligrams per deciliter, and yet she was already better. However, unsurprisingly, her water intake didn't decrease until we got to our final dose, where we were achieving interstitial glucose results coming down to 90 milligrams per deciliter, which was when she was treated with 24 units. And to sort of support my idea that this dog probably does have Cushing's is that we couldn't really see any detectable correlation of the glucose excursions with anything, really. There was just a whole lot of day-to-day and within-day glycemic variability. And I suspect that this dog does have endogenous hypercortisolism, and the owner never, ever wanted to investigate that. He just was happy once we got control of the diabetes. And so this is perhaps one of the most important things of all, is that CGM data is a really, really good tool to have in our tool belt when we're doing referral medicine with diabetic patients. And it will help us to solve problems. It will help us to understand problems. But once we have achieved our goal with the continuous glucose monitoring data to either find out what the problem is, or if we're trying to rapidly and efficiently get control of the diabetes, once we've got an idea that is consistently around 90 milligrams per deciliter, and I've put this in red because it's just so important, you've got to stop looking at the CGM data. You've got to take a step back. You have to not look at it, and you have to assess the patient's clinical control, not the glycemic control. You have to stop trying to fix the glucose results because at this point, you've probably got a huge improvement of diabetic control. The owner might be happy, and and we don't need to micromanage the situation or even intensively manage the situation anymore. We need to acknowledge that we have fixed it, that the animal's clinical control is better. We can do the Alive Diabetic Clinical Score again and say, hey, this exercise has resulted in your dog going from a score of 10 out of 12 to a score of 1 out of 12. And move on to less intensive ways of ongoing monitoring and a different part of the journey of the diabetes management. Thank you very much for your interest in this presentation. This is a slide that reminds you that the ACVIM welcomes feedback to help them improve their educational programming. And I thank you very much.